Okay. So I had issues with my Zoom saying that my audio isn't really being the best, but that's fine. So hopefully this time it'll work. But basically, I just wanted to give a sum over the stuff that we went over. So that's going to include the leadership and respiratory. So the way that Mandiola kind of sets up the exams, at least for the beginning, I knew it was gonna be a little bit difficult, to help just because she kinda cuts it off in, like, a really weird way, so that's why I had to ask a bunch of questions about where you guys left off. So I'm gonna try to do my best to summarize those things. For the leadership, it really is more about you guys just reading it, and I want you guys, honestly, to read it. I think that's the only thing that I would say. I don't really read the textbook that much, if not at all, but I would say for the most part, try to read the leadership stuff, just at least this paperwork that she sends you, and especially the study guide, just because she probably will ask a couple of questions in there. And I mean, I'll harp on the things she definitely will ask, but she could always ask other things that I know she wants. So in terms of this stuff, just read it and everything. In terms of the exam, at the end of this, we'll go through an exam review. I made some practice questions. I'll send it out to you guys. So we'll go over the respiratory, we'll go over leadership, we'll go over the exam questions. And I also just wanted to say that for Logan's class, I know that there is, I think for both classes, a concern about like that the work is really hard. And so I understand that it is very difficult to go through the semester and kind of be told that, it is probably one of the hardest semesters, if not the hardest. But I would say try to understand that it's it's worth it. I think you end up feeling pretty prepared. Of course, I think there is a difference between like taking this and like taking the NCLEX, which we'll talk about when the time comes. But um, I think the differences of what I've seen, like, from this program versus other programs, I think, BC is pretty well set, even though it is very hard. But I was gonna say for these exams, at least this first one for Mandiola's, I didn't think it was terrible. I think with the issues with both of their exams is you just needed somebody to kind of help you and tell you, like, what you need to know. So for Logan's class, I would definitely recommend to go watch Lauren, on YouTube. She has some exam reviews, so I would definitely try to go watch that. Some of my friends, they, um watched her and they thought if it wasn't necessarily helpful, at least it was something that they should have known. So it definitely didn't hurt. For other people, they said it really, really helped. So you can listen to me and hopefully, like my explanations help you understand some of the information better. But the fact that we have different slides and the fact that they're going to be emphasizing on different things and they have very different exams is kind of more of why I'm like, "I'm so sorry." But I definitely wanted to be kind of here for, um, both of you guys, but for Mandiola's class also, I just wish I was just going through, like, "Oh, I wish somebody would've just told me that." Like, it was just format issues, it was a lot of different things that, like, if somebody told you, you would've been fine. So, I think that's what the discrepancies were. But other than that, hopefully, I get to start, kind of being on top of this stuff. So sorry that I had to go test this week last minute and it worked out perfectly fine. But I really wanted to help you guys out more often instead of just throwing you this video literally in the middle of Saturday. So, regardless, okay, so I definitely would read this. I read the BRN stuff. I'm not going to lie. I didn't read all of it. That's crazy. But I just read um, like the top. Like, okay, generally for patient abandonment to occur, the nurse must have first accepted the patient assignment, thus establishing a nurse-patient relationship, and then the other thing is that they must have severed the patient relationship. So if they don't give a reasonable notice, that means that you are definitely abandoning the patient, and it has to be also you need to arrange those things for your patient. So if you know, like, say you get an emergency call, you have to leave. The issue is that if you just leave, that's abandonment. You have to tell your patient, and you better tell your supervisor or another um, somebody who's above you who can start working and taking your position. Just because, what if you tell the patient and then you leave? Well, you need to also tell the supervisor too, just because, again, who's going to be taking care of that patient? Right. So things like that, I would just go through the top really quickly and be like, okay, the nurse is responsible for providing safe. Okay, cool. Um, like this one you don't need to read. So basically just kind of like look through it and be like, okay, cool. So whatever she told you, kind of just read, skim. And then for this stuff, just read the pages, but more specifically, yeah, she talks about box 182, 183, 201, 201, 202. Read through it. And I honestly, I read through the pages and I thought it was helpful because some of my friends, they didn't. And they said, she did ask a couple of questions in which it's like, even if you just have read it, at least you're familiar with it. And so I felt like I did better and good on the first exam, in terms of, I think, like the second exam and the third exam, just because I at least did the reading for this part, and it's just leadership, so it's really not terrible, but if you don't know it, then of course it's pretty difficult. So I'm just gonna go over some stuff really quickly, things that you should know. The things that are highlighted in purple are pretty accurate. The one thing that I will say though is she doesn't ask. She says it's like you have to know it, but sometimes it won't even be on this exam. Like it'll be on the final, it'll be on quizzes and other things. So it's a little bit frustrating because it's like, oh, I don't know, but there are some stuff that she also implements into other questions as well. So I think for the most part, don't feel like you have to really study this part. I would just say read through it, and the stuff that I would study is kind of just thinking about like critical thinking questions of like how you would answer this question or how you would. It's more of like thinking, and it's more of like reading English type of thing. So like when we took the T's, we had the English portion. That's how I feel like about the leadership stuff. But anyways, so just gonna summarize some stuff. Again, the things highlighted in purple you should know, or she did emphasize on. Those things can change. So again, just know that I'm not 100% right in terms of all this stuff all the time because this was based off of my semester. But there are some stuff that I'm like, yep, she definitely will ask you that. So in terms of roles, I'm just gonna go through the first two because I feel like the first two and the last one, just because you kind of should be aware of this. So team nursing, that includes other team members. Super simple, straight to the point. Primary nursing, that's where you're sole caretaker. Um, in the NCLEX world and in comprehensive time, they will ask you these questions. So that's why I kind of wanted to talk about it. Advanced practice, that's just higher education, higher credentialing. So they're not nurses. They are nurses, but they took more steps, right? So nurse practitioners, CRNAs, you have to go back to school for that. Midwives, and then clinical nurse specialists as well. So critical care nursing. So we're talking about critical care a lot this semester. Additionally, Mandiola is a critical care nurse, and so is Logan. The definition is deals with human response to life-threatening health problems. So one thing that she kind of notes here is that is more of within the role. So she talks in the question, and I'll have it in the at the end, where you are a patient advocate, right, as a nurse. So if the question is saying, oh, I don't want to give away like the end question, but if the question is saying that the patient um, doesn't want to do something, um, doesn't want to take a med, you as a nurse should advocate for your patient. Be like, okay, you have every right to do that. So I'm not going to do that. And I will let the provider know. I'm going to note that they didn't want to take it, right? So if I'm doing something like I'm changing a dressing on a wound, if I'm giving them their meds, is that being an advocate? No, that's just doing your job, right? That's the actual nursing care part of your role. Has nothing to do with being an advocate. You're just doing what you have to do. But actually advocating for their beliefs, right? Telling them, okay, they don't want to get a blood transfusion because they're a Jehovah's Witness, and everybody is kind of making them feel bad about it or trying to tell them, no, like you should do it. No, like as a nurse, they don't want to. So I'm going to say, no, he doesn't want to, and I'm going to communicate his needs. That's being an advocate, right? But actually doing something, like in terms of like if I was actually giving like a blood transfusion, it's like I'm not advocating for the patient, I'm just doing the actual skill, if that makes sense. So that was more of like the English literal part that I was talking about in terms of the questions that she would ask here. But she kind of put that into a question and you'll see it later. So that's why I brought it up. For professional organizations, I would again read through this. She actually asked us, I think, about the critical care, the AACN, I want to say, yeah, mission. But it was worded a little bit differently. But the thing is, if you read all of it, you would have known, like, okay, that it was this one. And I didn't put it in the exam one practice question because I couldn't find like the exact thing. And honestly, I can see where she's probably going to change the like association she's gonna pick. But I would just read through it because, again, a lot of my friends who didn't read through this stuff, they were like, "Well, we don't need to know that. She didn't say that we had to know that." It's like, okay, yeah, she didn't, but it is technically all fair game. So I would just read it just in case, right? Don't feel like you have to study it. I just read through it, and then it's like when I was reading the question, I was still kind of like, "Ugh, I don't know," but I ended up getting it right, and I feel like it's because I just read through it. So, in terms of functions and benefits of professional organizations, they establish professional standards for specialties, right? So they tell us what should we be doing, what are the guidelines for that, and what are the policies for that. In terms of developing evidence-based practice guidelines, that's telling us like what are the research behind that? How do we um, as an organization help to bring more research to the table. And then improving professional practice and conditions, right? So our work practice, what are the burnout statistics, things like that, helping to improve our actual practice and how we feel as workers. So those are basically the functions of professional organizations. There's just three. And yeah, I just wrote to the side of things. That's basically how I would think about it. It's just like, okay, this is just filler, but it's fine. Just kind of look at it. She didn't ask us a question about this, but I do think, um, I want to say for the final, she might have asked a question similar to this. But either way, she said to harp on it during the time. She didn't ask us, but again, at least I read through it. Okay, and then we just have certifications, right? You guys can read through that. But see, this is what I was getting at. So I would just read through this because, again, it could be the case where she would ask something, and again, anything's for a game, but I kind of just didn't study it. It was just like, okay, read it, bye. So nursing license. So again, I'm not going to harp on this, but I think you should know that yep, we're in an ASN program. Other schools like CSUB are in a BSN. After that, you guys graduate and you take and pass your NCLEX, and then after you end up getting the license with that. And then basically the way that it works is so since I just passed the NCLEX, like I showed my mom, and it's on the expiration date was for 2026 in like March or May. And she was like, "What do you mean it's expiring?" And I was like, "No, like, remember, we have to take continuing educational courses." And she was like, "Yep, that's right," because she works as an LVN. But I was telling her, I was like, "Yep, I gotta take 30 units every, basically to keep my license active." So yeah. But the reason why we do that is basically because we need to keep updated with evidence-based practice, right? There are things that they had to learn that changed. My mom used to have to, she had paper like med um dispensaries. That sounds terrible, not having a computer and being able to scan and everything, but stuff like that, it's just important to know. But yeah, in terms of the purpose of California Department of Consumer Affairs, they protect consumers, right? And they make sure that all of these individuals are meeting their actual expectations of what they're supposed to do, right? So it's not just us, they also do like medical. So, um, medical assistants, CNAs, obviously MDs, dentistry, yeah, real estate. They go through the whole thing. Obviously in California, but they basically make sure to protect the consumers definitely from you know people who are um, in professional spots. So basically, I don't think she asked us a question about this, but she told us you should probably know this. So again, reading it through. Same thing with these ones, reading it through. She didn't ask us about care bundles or anything. Medication reconciliation, that's just basically making sure that your med lists are the same and accurate for your patient. So when they're transitioning on admission, discharge, transfer, you take even like their over the counter medications. You want to make sure you include everything to make sure we're not having any errors. This is also a good comprehensive question and an NCLEX question that was there several times. So NPA and then ANA Code of Ethics, I think we should just know this, but I understand how it's like bad to it's hard to get it confused and because we never talk about this stuff really. But basically NPA tells us like what we should be doing, like what's our scope of practice. So obviously as nurses we can't prescribe medications, right? Like how MDs do or physicians. So our scope of practice changes with like as we get a little bit older and let's say you end up going back to school, you want to be a nurse practitioner. Um, your scope of practice will change and you can actually prescribe medications. So that's how it kind of is changing the scope of practice. So NPA scope of practice tells us what we can and cannot do. And again, every single state has its own difference, right? Because keep in mind, I'm originally from Missouri. So the differences of what we can do over there versus here is a little bit different because of also patient population too, right? Um, so The purpose is to protect public safety, but really all that I think about is through the scope of practice. That's it. They tell me what it can do. And then for ANA code of ethics, that tells me how I should go about what I do if I don't necessarily ethically agree. Like what are the ethical guidelines for me? So basically they talk about ethics, ethics being the definitions right down there, what is morally right and wrong, right? I think we know that. But basically the ANA tells us, okay, you know, how do we go about this and holding up the standard of being a professional and making sure we're not having biased care to our patients, but at the same time, how do we address how we feel at the same time? So those are those kind of differences between those two organizations. But you don't really have to know that, but just in case, I wanted to go over it. Patient rights. So with a informed consent, as an RN, she doesn't test over this, but you will be asked this eventually. Um, or I can see it on a quiz, I could see it on a final, I could see it implemented into somewhere in this exam. But basically, like you can witness a signature, you can reinforce teaching. You can. The biggest thing is to assess their um, mental status, right? So you don't want to have a patient who is definitely altered and the surgeon is talking to them saying like, oh, this is what the surgery's going to be, and they're just like, yeah, I'm going to do it, right? You as a nurse can be like, nope, they're not competent enough, so let me go ahead and not approve of that. And so you are a witness to that, so you need to make sure the provider is explaining those risks and complications. But then again, okay, let's say your patient isn't um, altered at all and they have enough they're competent enough to understand, but they just don't understand what the procedure is. I mean, you as a nurse still cannot technically teach. I think the word like reinforce is kind of like, okay, you can reinforce teaching, but really in like test questions they don't say that. They just say like, okay, so you can teach the patient what to. No, just get the physician, get the surgeon, just have them explain it. Because they're also the surgeon. They're also it's like how we explain, "Oh, I'm about to put a Foley in you. This is how it's gonna go, okay? I'm about to, start an IV. This is how it's gonna go," right? Things like that. You explain it to them because you're the one who's gonna perform that. So I feel like it should come from that person too. So it kind of makes sense. But again, keep that in mind because she will implement that into questions. For Medicare and all that stuff, you guys don't need to know that. For abandonment, this is the one thing that you definitely should know, and she will test you on. Number one, so the BRN, their definition of abandonment, we talked about this earlier, but I definitely want you to read some of those documents a little bit. Um, First, you must have accepted the patient assignment and established a nurse patient relationship. That is the number one thing she will keep telling you. And so I do have a question, I think, on the practice sheet, but basically, let me ask a question. So if a nurse comes into, or she wakes up, she realizes that she's not feeling really well, and so she decides to stay at home and, but she doesn't, like, text her boss or anything. Is that abandonment? It's technically not. I mean, that's definitely not cool, and you're gonna lose your job, but, um, it's not abandonment because she didn't even go to the hospital, she didn't even accept the patient assignment, right? Okay, what if she did call the supervisor? Again, it's the same exact thing, okay? Nice for her to tell her, the supervisor, that's nice, but at the same time, still has nothing to do with her actually, going and starting, and accepting a patient assignment. In terms of, let's say a nurse who does go on the floor, she's getting, her report right now, um, but then she decides that she hears that her patient's going to be like somebody who's a criminal and she doesn't agree with that, right? So ethically, she's having some dilemmas and she decides that she doesn't want to take care of the patient. And so she tells her supervisor. Is that abandonment? No, because she technically didn't establish a nurse patient relationship yet, right? She didn't accept the patient assignment. If it basically will say they straight up like leave their patient. So yeah, no, you can't do that. So I guess the question is like, okay, a nurse comes onto the floor, gets shift report, is taking care of her patient. After a couple hours, she gets a family emergency call and leaves without telling anybody. Is that abandonment? Absolutely. Because the entire point too is that you also it's a 2 point factor too, right? Like you also didn't um give notice to the patient and you didn't give notice to another appropriate person who can make the arrangement to keep taking care of, the patient. So it is pretty obvious. So you'll see it, but just make sure you understand. Okay, like it could be a little bit tricky. Again, talking about literal sense, we're talking more about like English in some ways. Okay. So for floating, she doesn't necessarily talk about floating, but she talks about one of the factors that's in the second star. So floating is just based on the staffing. You have like closed units, and you don't necessarily need to know 100% what that is, but basically, some units are closed. Like there's no way that you're going to be able to go float somewhere else because they need certain competencies of nurses, and they need certain nurses who have certain experiences, and it wouldn't make sense to float other people out if they don't have that knowledge and experience, right? So for an example, if you're in L&D, right? I don't know if they're going to send you to they could send you to a med surge. That's fine, right? I don't know if they would send you to an ICU because those are two way different things. Same thing with NICU. I think that's probably one of the hardest places that you can probably float. It wouldn't make sense to be someone who only works in adult med surge and to then go work in the NICU setting. But they need another nurse. So that's why we're getting to that last part. So issues can include if an RN is not competent for a given or floor. Before accepting a floating assignment, the RN must have the proper knowledge and skills and should not accept the patient care assignment, right? So if you do accept it and then you realize you're not good enough and then you leave, that's abandonment, right? Um, and the problem with that is also like think about professionally, it wouldn't make sense for you to accept it and you're like, no, I can try doing it. And then you end up struggling and then you're just in a sense, kind of bothering other people's time and asking them a bunch of questions when you could have easily just been like, I don't know. So I think it is our duty as new grads to understand and kind of put ourselves in our own place a little bit of being like, yep, I do not know what I'm doing, so I'm not going to go to the NICU. I am not going there. But um, even if you're working after a while, I still wouldn't feel comfortable doing that. I probably still wouldn't even feel comfortable doing like L&D. But that's just me, right? But at the same time, you know your competencies, but at the same time, you have to be realistic with yourselves. Don't be like, oh, but this is a great opportunity for me. But no, it's not about you now. It's about the patient as well. So that's a question that they definitely will ask. If you're not competent enough to do it, don't do it. Okay. So, proactive planning, basically considering the past, present, future, and managers need to basically be informed about their legal, political, economic, and social factors. So, the strategies that they do, and the strategies that I think Mandiola tested us over was the SWOT. She didn't do the balanced scoreboard one, so I still don't really. I don't know why, but again, read through it, do what you got to do. But for SWOT, she did ask us specifically about that. That's strengths and weaknesses, opportunities and threats. So the strengths and weaknesses are the internal things, things that we can look at the so a manager looks at their organization internally, right? What are our strengths? We have great diversity. We have great people who can spill out ideas. Weaknesses, oh, we lack time management skills, things like that. Those are all things that are we have internally that we can look at. Whereas opportunities and threats, those are external things. So we technically don't have control over those things, right? So opportunities, what opportunities are being given to us? Do we have more ability as an organization to advertise, to market our organization? Threats, are there other companies that are doing the same exact stuff that we're doing? And we need to compete with them. So what are our threats to that? So that's just knowing strength, weakness, opportunity, threat. So vision and mission. So vision statements are basically okay. So you guys are getting into interview season, which is really exciting. I hope to make a video sometime in this next week, going over those information, and hopefully I can be cleared by HR so we can do like a Zoom session. But basically, you should know your vision and mission statements before you go to an interview. So if you're doing several interviews, which of course do as many as you can, um, I was gonna say make sure you know your vision and mission statements because they will ask you questions about that on the spot. They won't say like, "Oh, state it from memory," but they will be like, um, "Okay, so do you mind telling us like why what you relate with our mission statement? Tell us what you like about that." And it's kind of just like if you don't know what it is, you can probably take a guess and it's pretty all similar, but I think if you specifically know, like, oh, I think the biggest word, like, for more like the kindness aspect that you guys have when you walk through the doors, I think that's something that I said along those lines. So before you go into an interview, you should look up their vision statement, look up their mission statement, so at least you kind of have an idea. Um, so vision, those are the goals of the organization. What are our goals as a organization to be doing? So your goals should never basically be, or your vision should never um, always be one thing. It should always be changing. So the organization should never be actually bigger than their vision. And that makes sense, right? So our vision is like something that we see in the future. Like I would for you guys, it's like I vision myself in a couple months graduating and then passing and then after that it's passing your NCLEX and after that, start working. Um and you can have visions in all types of life, right? But that's like your goals. So it wouldn't make sense for me to have the same goals as you guys do, right? So you guys are looking forward, your goal and your vision is to graduate. For me, I'm already graduated, so it wouldn't make sense for me to for my vision to still be, oh, I hope to graduate. So it always should be bigger. So like after I graduated, it was like, okay, I'm passing the NCLEX. Okay, after that, now it changed, right? I just passed it this last week, so it's like, okay, now my vision should be, oh, I'm gonna start working and I'm gonna kill it, that type of stuff. So, if that makes sense, that's basically why the vision should always be something that they're aiming towards, so not something that they're already at. In terms of mission, that's just basically why the organization wants to exist in the first place. Like, what are they doing, and what do they hope to bring to this community? And what's our mission? So, like, our mission as like students would be, or as nurses would be, like, what's your why? Like, why you want to help people, you want to make a difference, right? And you should really believe that. That's what basically it's saying, that the organization should believe in their mission statement 100%. Yeah, it wouldn't really make that much sense for them to not believe in their thing that they put on their website. But yeah, make sure you definitely know those. Goals and objectives. Basically, goal, it's a desired result toward which effort is directed, and then objectives are explicit, measurable, observable, retrievable, and obtainable, but are more specific and measurable than goals as they identify when slash how the goal should be accomplished. And so I feel like even if you're gonna get confused, it's like they're basically the same thing. It's just that objectives are more specific. And I would literally think about it kind of like in class, like how we got like in fundamentals, like all those objectives, but there's also goals for us. But the objectives were super specific. Like um, if it would be on like a study guide, it would be like you need to know like this specific factor. So that's kind of how I thought about it. And for this stuff, she won't ask you, but you do, again, you should probably read through it and just know it just in case. Policies, what are our plans and statements or instructions that direct organizations in their decision making? And then procedures are defined as plans that establish customary or acceptable ways of accomplishing a specific task, right? So what are the procedures of having to accomplish the task? Policies is that what can we do in our decision making, and what can we set in place, almost like laws, practices. Okay, yeah, so managers should always include other people, or sorry, managers should include all people slash units involved within or affected by the plan. Absolutely. And then I don't know if she asked this on the first exam, but I definitely highlighted it and I definitely remember there was a question about it. I just don't remember if it was like the first or the final or whatever. But basically, unfreezing, movement, and then refreezing, it's just Lewin's change theory and basically talking about unfreezing. When the change agent convinces members that they need to start changing, okay, we're unfreezing it, people become discontent and then they are like, okay, we need to actually have a change. The movement is actually when we're doing and we're implementing those things. And then the refreezing is basically we're stabilizing the system so it can become into the status quo. It can be um, our regular what we're doing. So reading it, just making sure you understand that, and that's basically the summary of that. So then we'll get to respiratory right now. Okay, so now on to the respiratory stuff. I'm not only gonna go over some of this stuff because again, there's only some stuff that you actually have to know, but let's kind of get into it really quickly. So respiratory stuff, provide oxygen, eliminate CO2. We know that, it's great. So I'm actually gonna go over this stuff. So PaO2, it measures the amount of oxygen dissolved in the blood plasma. So P for P, right? And so that basically tells us how well oxygen is moving from the lungs to the blood. SaO2, that's talking about the percentage of oxygen bound to hemoglobin in arterial blood, right? So it has the A in it, arterial, and that again tells us how well oxygen is being carried by the blood. In terms of SpO2 and SaO2, they're literally essentially the same thing. The difference is that the SpO2 is like on the monitor and that's peripheral, right? So that's the peripheral oxygen saturation, and it tells us like a real time of like what it's going to look like. So it's literally the same thing, but technically, if we were to say which one's more accurate, it would be the SaO2. Does that make sense? I hope that makes sense because technically the peripheral ones, like we're just putting the finger, whereas with the SaO2, we're actually checking it in the arterial blood and seeing what it actually is. So in terms of ventilation, the nerve that we have to ventilate, it's autonomic. We don't have to think about breathing. So it's just regulation of breathing, right? So with compliance, that's basically means stretchability. So having that stretch of being able to move our lungs, inhale, exhale, do what we have to do. So that obviously can be affected by different factors. So obesity, ARDS, pulmonary edema, pulmonary fibrosis. So if you're stretching and you have all of that stiffening and inflammation, that stretching is going to become way harder to do that. And that makes sense, right? So I want you to think about the lungs like during this entire respiratory thing, I just think about the lungs like it's straight up a balloon, especially when we're talking about ventilation. And we start talking about the ventilation settings. I just think it's super helpful to think about it like that. So if it's too stretchy, if the balloon gets too stretchy with things like emphysema, it's not like even if you put air into it, it's just not, it's gonna stay flat, right? So that's basically what we see with like destruction of having too much stretch. So you just want it to be right, perfect, right? So I actually had this wrong on the study guide that I had. I updated it, but I was reading it through, and when I was doing a recording, I was like obviously going through this stuff before I started recording, and I was looking at it, and I was like, "That's not right." So basically, it's the same stuff, and you guys know it. I've talked about it before, and basically, we're talking about the muscles and the diaphragm and all of that stuff. Of course, like the diaphragm, the intercostal muscles, they help us to inhale and exhale, but that we're talking about like negative and positive pressure, but I'm gonna change that to high versus low pressure because I feel like that can get confusing. So I'm gonna kind of change that. But yeah, I noticed that I think I did it the opposite way. So I apologize for that. So that's why I also wanted to just go over this again one more time, just because even though I talked about it before, I did write it wrong here. So that's why I was like, no, and I noticed it and I was like, okay, that's definitely not right. But I feel like when you're saying it out loud, you'll be like, "Oh, yeah, no, that makes sense." So for the diaphragm, the weird thing is I used to get this confused as well because it contracts, and when you think about contracts, I feel like it's just a weird word. I don't think about it flattening, but it contracts and it flattens. So basically, in terms of your lungs, right? Just imagine it. It basically your diaphragm moves down, it contracts. Now your lungs have more volume, so because they have more volume, they have less pressure. It's the same exact stuff when we're talking about like blood vessels, right? If the blood vessel is bigger, we have less blood pressure, right? Um, basically it's the same exact thing, right? So this action, when we're inhaling, basically increases the volume. So we decrease the pressure, right? Because it's bigger. And basically it causes the air to flow into the lungs because the air from the outside is really high. And now we're going into a low type of pressure because of our lungs not having we have a lot of volume. So I hope that makes a little bit of sense. So basically with expiration, during exhalation, the diaphragm relaxes so it moves back up. And so now we have less volume in the thoracic cavity. And because we have less volume, there's more pressure, right? Think about a blood vessel, we have less dilation, we have more pressure, right? So because we have more pressure, the actual pressure pushes the air out of the lungs. So again, we have high pressure in the lungs, low pressure in the environment. So the air moves back, um, and we repeat the process all the same again. So I hope it makes sense. So basically, we're going from, I guess, in a sense, we're going from a high to low pressure, a positive to negative pressure for that. And then for the intercostal muscles, that's just helping us out, right? So doing what it needs to do to help our diaphragm, to help our lungs be able to expand. And yeah, I feel like you don't even need to know that for that's the same thing. So yeah, reduced volume would increase pressure. So like literally think about like blood vessels and then literally act it out. So anatomical dead space. So when we're talking about this, it is kind of confusing, and even I still kind of am like, but basically what it means is that, and when you are in the ICU, there is dead space within the vent. Um, so basically what we're talking about is the actual gas exchange. So this refers to where air is not participating in any gas exchange; it's just strictly going down. So really, the only thing that kind of is like the bronchioles and like the alveoli, because but really we know that gas exchange is where um, it occurs in the alveoli, right? So like the nose and the mouth, the pharynx, the larynx, the trachea, the bronchi, like all of those things are getting air, but where's the actual gas exchange occurring? More in that alveoli, right? So the rest of that stuff technically is dead space. So that's basically what it's saying. But you don't really have to know that really in depth. Again, it's just something to kind of start thinking about it. With airway resistance, I feel like you can read this and it makes sense. You're going to have resistance with those things. For cardiac output and RBC transport, it definitely makes sense to have stuff like that, uh, to kind of read it. But again, I feel like it's pretty self-explanatory. You guys already know RBCs, hemoglobin, all of that stuff. So read it, make sure you understand it. Gas exchange, make sure you understand that kind of, just because again, when we get into like these vent settings and stuff, again, it would be really helpful to understand that. But really, all you have to know is there's different types of gas exchange. So let me go through it really quickly, just in case, because I feel like honestly, it's not that bad. Okay, to kind of keep, going on, I just had to record, or I had to stop recording because I had to charge my iPad. But anyway, so gas exchange, basically, I think if you understand this, it'll help to understand like the VQ, perfusion ventilation ratio thing. It'll help understand the intrapulmonary shunt thing that they go over. But basically, what it is that with ventilation, it consists of movement of gas, so O2 and CO2 at in and out of the alveoli, right? So ventilation. Diffusion, this is what we're talking about at a pulmonary capillary level, right? So O2, CO2, basically they go through the alveoli, they cross that capillary membrane. And so I kind of think about it almost like we're talking about like with sepsis, how we were talking about last semester with like capillary permeability and like fluid shifting. It's kind of almost similar, but it's different, right? Like with obviously because that's more with fluid, this is actually with um like air. So because of that, we're more talking about like diffusion, the process of diffusion, right? So because of that, the gas molecules they move again from a higher to lower pressure. So the O2 pressure is higher in the alveoli. So that means that the oxygen get to go from the alveoli to the blood after they cross that capillary, obviously. And then for the CO2, it's higher in the capillaries, but then that allows them to cross, and I'll kind of show it later in a second, that allows them to cross the capillaries to go to the alveoli, and then that is then exhaled through our lungs. So basically, this is what we're talking about with diffusion. So not only, so basically, how does like our hemoglobin have oxygen? Well, obviously, we have to inhale it, and then we have that process of diffusion where it crosses the capillaries and that kind of thing from the alveoli. And then at a cellular level, basically the O2 goes from the blood into the cells, CO2 leaves the cells, and it diffuses into the blood because obviously it's a waste product. It gets picked up, and then it goes to the pulmonary capillaries. So it's diffused now into the alveoli, and then it's in the alveoli. Again, we're talking about gas exchange. Then we're able to exhale it. And then organ perfusion. So again, just through this, the oxygenated blood, right, comes from those pulmonary capillaries after they've been diffused from the alveoli. It's transported then to the vein, left side of the heart. We go through that whole entire system of blood flow, and then basically that's how our tissues and organs get properly perfused. So again, with the transport going into oxygenation, you guys know that hemoglobin is the one that carries the oxygen on the RBCs that goes to the lungs and the tissues. So that's just kind of going through that information right there. So in terms of organ perfusion, you have to make sure you have enough blood volume. That definitely makes a lot of sense. If I'm having a GI bleed or a bleed in general, basically the problem with that is if you don't have enough blood to be able to have oxygen bind to the RBCs, the hemoglobin, there's nothing really that you can do. So really, that's why we carry so much weight when it comes to looking at the patient's blood pressure a lot, especially in the ICU, because that means your organs are not being properly perfused, and that's why we look at like their creatinine, we look at their liver enzymes, we look at like if they're jaundiced, their altered mental status. There's so many different things that go into these factors because you don't want to make them worse. But if you don't have enough volume, you can't be oxygenated. There's just no way. There's nowhere that the oxygen can go. So for preload, that's just talking about the volume of blood in the ventricles before contraction, heart rate, how many heartbeats per minute, right? How much is the heart working to get the blood pumping out to the rest of the body? Blood pressure, again, it's talking more about the force, but again, still talking about how well we can see if the um, blood is being transported and if they're perfusing our organs, and then organ function by itself, right? Just to make sure they're being perfused. Cellular oxygen demand, uptake. So I wanted to just like read it because then we're going to talk about the oxygen affinity and that entire oxyhemoglobin curve thing. So with body temperature, higher temperatures increase the body's demand for oxygen. I think we all know that because of the elevated metabolic rates of what's happening. And then oxygen extraction, cells extract oxygen from the blood to meet their metabolic needs. The process can be influenced by the availability of oxygen and the cell's metabolic demands. So if your body knows that it has a higher metabolic need, it's going to ask for more oxygen, or it's going to try to get as much oxygen as it can because it needs it, right? So now when we're talking about the oxyhemoglobin curve, okay, so let's talk about it. I would think about it, and I understand how it's easy to get this confused. I would think about it like this. What does affinity refer to? Affinity refers to attraction. That's exactly what it means. So if we're talking about oxygen affinity, we're talking about O2 um, affinity basically means how strongly the hemoglobin, because remember hemoglobin carries the oxygen, binds to oxygen. So how strong is the hemoglobin binding? How much hemoglobin is attracting the oxygen? Like they want to stay together. That's basically what oxygen affinity is saying. So on the left hand of the side, you have increased affinity. So you have increased attraction. So basically, what that means is that the hemoglobin is staying onto that oxygen because they're attracted together. On the right hand side, you have decreased affinity, right? That means, okay, less attraction. So that means the oxygen and the hemoglobin aren't binding super well together. Okay, so now when you look at the factors, let's look at the right one because that one kind of I feel like makes more sense. Less attraction, right? So less attraction, hemoglobin not binding to oxygen. And the reason why it's not is because there's an increased metabolic need when you look at all of these factors because these factors need more oxygen, right? If I have a lower pH, I'm in an acidotic state, right? We're talking about like sepsis. If I have a higher CO2, right? That's a higher acid. If I'm having a higher temp, so basically higher metabolic needs, these things need more oxygen, right? For these factors, well, the good thing is you only have to memorize. If you want to memorize it, you can. Obviously, one of them is only decreased. But I feel like if you actually understand how this works, it's pretty, you don't even need to memorize it. It's just understanding the concept, right? So when hemoglobin has a low affinity for oxygen, it binds to oxygen less tightly. So basically, hemoglobin is more likely to release the oxygen to the tissues, and that's where we need it. So then the body's going to be able to pick up that oxygen and everything there. So I hope that kind of makes sense, but I'll summarize it here in a second. Whereas on the other side, right? So on the other side, we have the left hand side, an increased affinity. So we have more attraction. So that means the hemoglobin is attracted to the oxygen. They're staying on there. You know why? Because we're in an alkalotic state. We have a lower CO2. We have a lower temp, right? And I think about it mostly for this one. I think about mostly hypothermia, right? Because like if you're cold, you don't need more oxygen. They're not having an increased metabolic demand need for oxygen. Um, so when hemoglobin has high affinity for oxygen, it binds to oxygen more tightly. This means that hemoglobin holds onto oxygen more securely and is less likely to release to the tissues. It's good for picking up oxygen in the lungs, but can make it harder for the tissues to get the oxygen they need. So literally on the right hand side, decreased affinity, less attraction, right? If we're having less attraction, the oxygen is able to go and leave, and then it's not binding to the hemoglobin, so our body can actually use it. Whereas on the left-hand side, we're having increased attraction. It's sticking to the hemoglobin because your body doesn't need the oxygen. The hemoglobin is going to keep it, and it's going to keep it there. It doesn't need, if you're having a lower temperature, it doesn't need that extra metabolic demand. It's decreased metabolic demands, actually. So I hope that makes sense, but let me go ahead and go into reading this because it kind of talks about the same exact thing. So the oxyhemoglobin dissociation curve shows how the body should respond to different conditions, such as temperature, pH, CO2, and how the hemoglobin will actually bind and release oxygen due to what the body actually needs, right? So with rightward shift, we know that the affinity is decreased, so there's less attraction. So this indicates conditions where the body needs to release more oxygen. So because the body needs to release more oxygen, it's going to have decreased affinity because it wants less attraction. The hemoglobin wants less attraction to oxygen. It doesn't want to, they're not attracted to each other. So the curve shows that a given PO2 hemoglobin will be less saturated with oxygen, reflecting easier release. So really what it's meaning is that it's just not binding to it. And that's a good thing because we need that. We want that oxygen from I want it. Hemoglobin doesn't need it, I want it. Whereas with the other side, the leftward shift, this indicates conditions where hemoglobin holds onto oxygen more tightly because increased affinity, more attraction, right? I'm going to keep repeating it so it can get in your heads. More attraction, so it's going to hold on. Hemoglobin and oxygen, they're besties, they want to stay together. So because they're besties, because they're attracted, they want to stay together because the left-hand side, lower temperature, higher pH, lower CO2, they don't have an increased need for oxygen. They're going to just hemoglobin and oxygen are just going to stay together. So they're not going to be released more. So that's what it's talking about when we're talking about affinity. Just think about attraction and think about how, sepsis patients, people who are acidotic, that people with higher CO2s and higher temperatures need more oxygen, right? So because of that, hemoglobin says no. I don't want that oxygen. I'm not attracted to it. So less affinity. So that's how I would think about it. Hope that makes sense. That's how I thought about it. And I know they can get confusing, but really, and then the other thing that you only have to memorize is that on the right hand side, you have less affinity. On the left hand side, you have more affinity. So other than that, there are causes of hypoxemia. There's hypoventilation, other things like that. But let's go into talking about the intrapulmonary shunt and the VQ mismatch, so we can also talk about some of those things I was talking about earlier with the 4 different types of gas exchange. So with hypoventilation, low PO2, high PCO2. So obviously, if you're having anything like that, where you're having opioid overdoses, COPD, asthma, anything like that, yeah, that makes sense. So intrapulmonary shunt. So if you look at the picture, you see how there's a collapsed alveoli? So basically the normal one should look like that. So let me see, I have my pencil right here. So here's the alveoli. That's really big. Here's the alveoli. Here's the pulmonary capillaries right here. We have the vein and then you have the artery, right? So the alveoli, you inhale, you get the oxygen picks up, goes to the pulmonary capillaries. That's what we mean by capillaries, moves onto the veins, the arteries, and now it goes through that whole system of going through the heart, oxygenating the blood, and all that stuff. And then CO2 also is in here, and it goes back to the alveoli, and then it's going to be exhaled. So that's basically what I was talking about earlier. But when we're talking about the intrapulmonary shunt, basically this means the blood passing through parts of the lung where effective gas exchange does not occur, which leads to hypoxemia and reduced oxygenation. So really what it's talking about is the alveoli collapse kind of, or something similar to that, condition similar to that, where there's a problem wrong with the alveoli. And because of that, we have hypoxemia to the capillaries, veins, and to the rest of the body, just because, again, that O2 isn't going to be able to be closely connected to those capillaries to be able to go out to the rest of the capillaries and blood and yada yada yada. So other than that, that's kind of how I would think about it. For VQ mismatch, it's going to be basically V meaning ventilation, Q meaning perfusion, right? So if I'm saying um, high VQ mismatch, basically what I'm saying is that the ventilation exceeds the perfusion. And if I'm saying low VQ ratio, that means low ventilation versus we're having pretty good perfusion, right? So it always goes with the ventilation first, if that makes sense. So it's like high ventilation. That's what we're talking about for that. So let's talk about high VQ ratio. It occurs when ventilation exceeds perfusion, right? Because it says high VQ. And so this can happen when there's things like a pulmonary embolism, there's a blockage in the pulmonary artery that reduces blood flow to ventilation. So the alveoli is in charge of that ventilation, right? That gas exchange. But because there's a blood clot, we're having less perfusion, right? So in this one, it would be the high VQ mismatch right here, just because, again, we're having more ventilation here. But because there's a blood clot, the O2 can't really come in here and then leave. So we're not having the perfusion because it goes out to the rest of the body. And then if I was having the low VQ ratio, that means I'm having obviously low ventilation, and then I'm having pretty good perfusion. So this doesn't occur when basically you're having cases like bronchitis or pneumonia. So the airway is impaired, but the blood flow is fine. So there's would just be less O2 as a whole because you're struggling to kind of breathe. And obviously there wouldn't be a clot, but you're perfusing fine. It's just that the alveoli is the main problem of this. So that's basically what it's saying when we're talking about VQ mismatch. Which one is the problem? Is it the ventilation or is it the perfusion problem? Like if you're having a blood clot, you have to fix the blood clot, but it's not a respiratory issue when it comes to the actual ventilation process. The alveoli they're getting the oxygen. It's just that there's a blood clot blocking our blood vessels, so we can't be perfused. So our organs is what we're worried about. Whereas with the other one, we're having a low VQ versus the perfusion. What we're having there is that okay, there's not a blood clot, there's nothing wrong, we're perfusing fine, but we're not technically perfusing fine. It's a ventilation that issue, and the ventilation process is not working. We're having not enough oxygen, so then that's what's causing the issue. So you'd have to tackle both of those things. Um, that's just determining like what's your problem. So I hope that makes sense. And then obviously with interstitial fluids, this basically just plays a role in gas exchange. Because obviously if you have more excess fluid, it can be difficult to have the distance for gas exchange to occur. So it's a blurry picture. I apologize. But if we're having more interstitial fluid here, when it's trying to diffuse into the capillaries, that O2 from the alveoli to the capillaries, and you're having more fluid and everything, it could just be getting more difficult, right? And that makes sense because it has to travel more and so on. So she actually did ask us some age-related changes, but of course, I feel like age-related changes are probably some of the easiest questions you can get. We love it. So I put some pediatric and then geriatric considerations. Definitely read through that, but just remember, everything's worse except for the work of technically your work of breathing is higher, but literally everything is worse because you don't want a higher work of breathing. So sometimes I just think about it, try not to memorize things, just try to truly understand it or just try to find one thing that's different, right? So of course, the only thing that's high on here is the work of breathing. And that makes sense because you're having a harder time to have to breathe, so you're having to work harder. Whereas with the other stuff, I'm pretty sure she put kyphosis on there. Yeah, it's something to consider because now they're bending over and now you have all of this weight kind of on your lungs, and you have osteoporosis, spinal degeneration, um, and then calcification of the cartilages. So all of those things, just definitely read about it or just look at it, and you'll get that question right if she asks you guys that. So I definitely would know these terms. She did ask us. There is a picture that kind of emulates kind of the respirations and everything, but I'll go through that as well. So respiratory rate, eupnea, tachy, and then brady. You guys already know those things, right? So dyspnea, orthopnea, like you guys, nocturnal, like you guys know those things. Like they're pretty obvious. The ones that she actually asked was about Kussmaul's, Shane-Stokes, Byatt's, and then apnistic. But what I would say is, I have a question on there, but Kussmaul, as you guys know, is with DKA, deep labored breathing, rapid respirations, right? And again, you can look at the picture over there. Shine Stokes, this is alternating periods of deep, rapid breathing and shallow breathing and periods of apnea. So we have a bunch of different things. So I don't think she'll ask you like what diagnoses, I just put those in there, but it's more about like what it looks like. Um, for Byatt's or whatever, that one, it's more about irregularness. I think that's how I would think about it, is that that one's just irregular because that one also has deep reps. It also is rapid. It also has periods of apnea, but it's just super irregular. Like if you look at it compared to the rest of them, like it's highly irregular, abrupt pauses. And then the other one with Shine Stokes, respiration's gradually increasing. They become shallow, and then we have apnea. So there's that. And then with the last one, prolonged inhalation followed by short, insufficient exhalation. So inhaling in, short out, and that's where you see that there. So just make sure you know those because she did ask us about that, and I will be asking you a question on the exam review. So for these, go over it. This was technically from a couple semesters ago, but I watched a video because they recommended it, and it is pretty good. It's I think from I forgot who it's from. Sarah, the girl from the nursing videos, and she goes over all this stuff, and I do think it's helpful to know. So, I did highlight like this stuff, but I don't even think you had to know that. I just read it, and this was me just making notes at the time whenever I was studying. But really, like these are pretty obvious. I think the one thing's it's like subcutaneous. You hear there's air in the subcutaneous tissue. Crepitus, we know that. Tracheal deviations. But honestly, I think the only thing she did ask us a question on here, and it was about crackles. And obviously, with crackles, what diagnosis are we usually thinking? Pneumonia, right? So that's pretty obvious. And then wheezing, like usually, it can be associated with asthma, a stridor, like anaphylactic reactions. So definitely just read about those things. And then I also put the pack years on here. She didn't ask us that, but I was really paranoid because she was like, everything's fair game at this point. So I kind of was like, okay, but basically that's what's going on for that. So for the ABG results, in addition to understanding the partially compensated, uncompensated, you guys know that stuff now. All that you're adding to it is now you're looking at both of them, if they're both going in the direction that the pH is going, in terms of like, okay, so let's say if I have a pH that's acidic, right? So less than the 7.35. And then let's say I have CO2. CO2, the normal range is 35 to 45, right? So CO2 is an acid, right? And I said that my pH was acidic. So CO2 is an acid, and I say that my CO2 is like 50. Okay, right now you're thinking respiratory acidosis, right? That's what do you do? You just go down the line, and then we're gonna look at the bicarb. Okay, I'm looking at the bicarb. Bicarb's a base, right? So if the bicarb was super low, so it's like 22 to 26 is a normal thing. If I say it's like 15, that is also technically in an acidic state too, right? So now I'm like, okay, they're both causing the pH to be acidic. So in that case, you would just say mixed acidosis. One thing to know is you will not say uncompensated before or like partially compensated, compensated. Just don't just say mixed acidosis, right? Um, some people they would put like uncompensated mixed acidosis, but she'd be like, you don't know. So just put mixed. And then additionally, the new thing that you guys were adding is the hypoxemia, right? So then you'll just look at the value. If it's less than 80, you have hypoxemia. If you don't put anything. Don't put like without hypoxemia, or that doesn't make sense. Just put what it is, what you see, and that's it. In terms of like understanding their relation, you know who I actually with reviewing the NCLEX, you know who I actually think explains it really well is Mark K. And I actually wish I would have listened to him a little bit in nursing school. So if she ever gives you like values like this, he has this saying, and I think I have a picture of it. I do. It's called the rule of bees. And it basically means that if the pH and the bicarb are both in the same direction, it's metabolic, right? So you just look at pH and then B, B, B. So if the pH and the bicarb are both in the same direction, it's the metabolic issue, right? And then you just go based off of that. And yes, I would recommend to draw the arrows and then look at it. And then the only thing that you're adding now, it's like if they're both going in the same or not the same direction, but if they're both like acidic or alkalotic compared to the pH, you'll just put mixed. So I hope that kind of makes some sense. And then we'll get to the other thing later. But basically, I don't think she'll ask you any like symptoms, but she did ask us if a patient is in like respiratory alkalosis versus respiratory acidosis, you need to understand what the differences between those two things are. And all you have to know, you do not have to memorize all of the different like signs and symptoms or causes. All you have to know is the concept of it, right? So for respiratory acidosis, what does that mean? Okay, pH low. So CO2 is the respiratory buffer, right? So if I'm looking at CO2, I know that's an acid. So if I know that's an acid and it's, we're talking about respiratory acidosis, I would expect the CO2 to be high, right? So because it's high, it's like, okay, are we hypoventilating or hyperventilating? So again, it's high. That means I'm not hyperventilating. It means I'm hypoventilating, right? Because it's like this, right? I'm going to keep all the CO2 in me. I'm not going to breathe. That CO2 is going to build up, and then again, CO2 is an acid, so because it's high, looking at your pH, it's low, respiratory acidosis. So all you have to remember for respiratory acidosis, basically what that means, hypoventilation, always. So keep in mind too, what about if I say something like sepsis? Well, sepsis is a metabolic issue, right? If I were to say a type of breathing that's been caused from sepsis, at the same time, yeah, that actual breathing part can be a respiratory issue. But again, she's not going to say something like that. I think she just said like straight up sepsis. And it's like people were thinking, oh, but you do hyperventilate or you can hypoventilate with sepsis. But it's like, it's still a metabolic issue. She specifically should say like breathing, but if I were you, I wouldn't even put it. I would just put these are supposed to be respiratory issues. If it's respiratory, it's respiratory. She'll put hyperventilation. You know what I mean? She'll put hypoventilation. So really, all you have to know is respiratory acidosis, hypoventilation. I don't want to hear. other like kidney issues, anything like that. It's always just hypoventilation. For respiratory alkalosis, well, it's just you can memorize one, right? So if one of them's hypoventilation, all you have to remember is the other one's going to be hyper. But if you think about it, respiratory alkalosis, CO2 is an acid. So alkalosis means that I'm more base, so the CO2 would be lower. So if the CO2 is lower, so it's below the 35, the obviously the pH would be high. You're thinking, and it's like, okay, so that means I have no CO2. I'm not retaining CO2. So I'm probably breathing really fast because again, CO2 is released as we exhale, right? So I'm probably breathing fast, getting rid of all of that CO2, no CO2 left in the body, and therefore I'm alkalotic. So hypoventilate, hyperventilate, that's all you have to know. And that's what I would think about it. Respiratory alkalosis, hyperventilate, respiratory acidosis, hypoventilate. And then it's like you just look at the stuff right after, right? So respiratory with acidosis, it's like, okay, if they're hypoventilating, then it's like, okay, yeah, they probably are overdosing. They probably are struggling to breathe, things like that, right? They're choking. Anything like that is what I would just think about. But that's all she would ask you. I don't think she would ask you a metabolic issue because one, we're in the respiratory lecture too. So again, I don't know if you guys went over pulmonary embolism, but I'm going to go over it. So an embolism is a clot that basically, I think we all know this. I think this is super simple. Don't overcomplicate this. Again, understand the concept of it. I think the other ones, as we get through like to next week when you learn about ARDS and all that stuff, unfortunately, like it is kind of, but it's understanding the key things that she points out, right? So if they say like a patient comes in and they had a DVT in their lower extremity, you should probably maybe think, and now they're short of breath, all that stuff. You might want to think that they're having a PE, right? Because that's what she does harp on as the most common cause. But basically, an embolism is a clot that moves through the vasculature until it eventually lodges in a small vessel and can no longer pass. And once it's lodged into a pulmonary vessel, now you got a pulmonary embolism. Common cause DVT in the lower extremities. First symptom and evidence is sudden death. So 25% of those have a PE. But really, like for your risks, I feel like it's going to be the same stuff, right? Immobility. You're getting hurt. The one weird ones, and this is what I usually do, is I think I point out the weird ones because all you have to remember is the concept, and then if there's something that's weird, then you just add that onto it, right? So oral contraceptives, kind of weird that it causes a lot of PEs, but it's very true. And same thing with IV drug uses. Um, Kind of makes sense though. Like I feel like anytime if you see smoking, drug abuse, it's always going to be a risk factor, right? But for the oral contraceptives, that is asked a lot in the farm. That's a lot asked on the NCLEX a little bit too. And you all get different NCLEXs, but I mean in terms of questions, you'll see you don't want to give those to people who have history of DBTs or PEs. So those are all kind of things that we know, like sepsis, of course, strokes. It makes 100% sense. Ischemic strokes, immobility, absolutely. Lengthy trips. That's why, like, our phone or our like Apple Watches will tell us to get up, right? Because you've been sitting down too long, and you have more of that stasis. So, because we're getting into the etiology, so the causes, it makes sense why, like, if you're having immobility, it's because you're having venous stasis. All your blood is staying there. There's more chances of being able to clot. So it can be caused from obviously a DVT, fat, vegetation from the heart valves, fragments from clots, from a catheter, amniotic fluid. Again, won't really ask that, but she will ask. Again, we didn't have these questions on our first exam, but just in case, Burko's triad, venous stasis, hypercoagulability, and vessel wall injury. I know this was for sure on the final, but yeah, venous stasis makes sense. If you're staying together, it has more ability to clot. Hypercoagulability. So now it's just saying all that means is that you just have to understand the English, right? Hyper, so it's high, coag, clot. So it's basically saying, and then ability. So basically, high clot ability. So that's basically saying you have an increased tendency for the blood to clot. And again, that can be caused from like cancer, pregnancies, certain medications like oral contraceptives, and genetics. So it makes sense because sometimes it's like, oh, we need to make more blood clots because we have other issues. So those are things there. And then vessel wall injury. So obviously, if you end up, getting hit by something and your blood vessels are having like a hemorrhage, yeah, that means that there's probably some damage to it, and that can trigger a clot to basically form. So trauma, surgery, atherosclerosis too, it can break off from that. If you end up like um, getting some of the plaque off. Now you have that vegetation and it comes off. Now it's a clot. So you have that. It's just specifically, of course, pulmonary. in the pulmonary. Manifestations obviously are going to be related to respiratory issues, right? So sudden pleuritic chest pain makes sense. Shortness of breath, and then hypoxemia, because eventually you will see that they're not able to breathe. Um, so other than that, diagnostics, when you're going in for a DVTs, even with a stroke, first things that we do is we get them prepared for a CT, right? So that includes PEs as well, right? It's going to be a CT. The gold standard, though, is a pulmonary angiograph, and that makes sense because you're wanting to look at the vasculature, right? Ultrasound of lower extremities makes sense. You want to see what's going on there, and of course, that was one of the most common causes. VQ scan. So again, like, is it more of a ventilation issue? So if it's a ventilation issue, that means that something's going on with the alveoli, right? But if we're talking about the VQ scan, we also just want to see if, remember, one of the causes was blood clots. Because what if the perfusion aspect, you're breathing, but what if it's just the clot in your vessels, and now you're not being properly perfused, but it's not a ventilation problem, it's a perfusion problem. And then the D dimer. So, right, the protein produced and sensitive to the clots. But again, that's not specific to the site. That's just to tell us, oh, yeah, that it can help your diagnosis, basically, but it can't diagnose it by itself. So, supportive testing, and it makes sense. Checks X ray, ABG to look at your PaO2 too, to see where it's at. Make sure you're breathing. You're getting that enough plasma. Um, Oxygen in your plasma. And then basically, with the echo, it makes sense too to see what's going on with the pulmonary arteries. And then basically too, when we talk about the complications, we also want to just look at what's happening to the heart, because again, with the blood flow system and all that stuff that we learned, it can back up, right? So that's where you see that. And for the complications, I mean, it makes sense. You're going to have respiratory distress. You're going to have pulmonary hemorrhages, pulmonary hypertension, right? Those all make sense because they're all related to pulmonary. The weird ones, and of course, obstructive shock makes sense. It's an obstruction, and then sudden death, of course, but always. But I was going to say, I think the weird one is right ventricular heart failure, right? Because again, if you remember the anatomy, the veins bring back blood to the heart, but if they were having a clot, it's going to start to build up. So prevention, I think we all know, it's the same thing as DVTs, embolic hoses, SCDs, anticoags, aspirin therapy. But again, they're having a bleed, you want to kind of be cautious about that. But again, risk benefits, they have other treatments for that too. And then treat dysrhythmias, of course. Um, for management and treatment, oxygen, mechanical ventilation, thrombolytics, so those ACE medications, right? And they have to meet that criteria for that, but you don't have to know that specifically, but you just know that you can give these meds, anticoags, and obviously you have those ones. And then remember the heparin with the PTT, warfarin with the PTINR, and then the vitamin K, and then obviously for the heparin, protein sulfate. So other things that you just need to know, but she did not test over those things anyways. Inferior vena cava filter for surgery. They place the filter, traps the clot, get to remove it. Yay. Embolectomy, you take out the clot. Super simple, super effective. Love when diagnoses are super simple like that. The only weird thing that you have to know really is just the Verko's triad, but if you actually think about it, it makes sense, right? I think the only one that can be a little bit confusing is maybe vessel wall injury, but I feel like it does make sense. And I would just think about it like, oh, if you have plaque on your wall, you get hurt. You can even dislodge some of the plaque from your wall, and it can start the clot. Um, and also because it's damaged there, to your vessel walls, it's gonna wanna clot. Remember, like with sepsis, we want to clot to prevent the infection. It like goes to that site. If your vessel walls are hurt, it's going to clot up and try to protect that. Okay, so this video is gonna be so long. I'm so sorry. Okay, so type 1, hypoxemia. Type 2, more CO2. So it's like low O2, high CO2, right? Um, Basically causes intrapulmonary, pulmonary related, extrapulmonary, like heart failure, right? So now you have too much fluid that's making it hard to have you breathe. So I would just think about it, yeah, type 1 oxygen, type 2 CO2. So I would think about it, it's type 2 and you have CO2, so I would just think about it like that. Negative pressure. So that's why I wanted to explain like the negative and positive pressure things. So basically, negative pressure that includes the iron lung and that other thing. I'm not going to say it because I feel like I'm going to butcher it. But negative pressure ventilation works by creating a vacuum around the thoracic cavity, right? So causing the chest to expand. And because it's expanding, we're having less pressure, right? So basically, The expansion decreases in thoracic pressure, allowing the air to flow into the lungs, positive to negative pressure, just like what we talked about earlier. For positive pressure, we're talking about ventilators, right? So now it can get a little bit confusing, but hopefully I can try to explain some stuff. So, assist or take over a patient's breathing, obviously. In positive pressure ventilation, air is pushed into the lungs through the airway using mechanical force, and usually it's going to be through a mask, it's going to be through an ET tube or a trach, right? So, when we're talking about ventilators, we're talking about the difference between pressure and volume, or both, because ventilators will use both. But some of them use more volume, some of them use more pressure, and you'll get into talk about that next week with Mandiola. But the way that I would think about it is, again, we're going back to the balloon example for the lungs. So if you have a balloon and it's your lung, the pressure refers to how much push is needed to get air into the lungs. So how much how much force I'm pushing when I'm breathing into the balloon, how much force am I going to breathe into that balloon, right? So the advantages to that, the pressure is limited and there's a decreased risk of barotrauma. So what is barotrauma? I would think about barotrauma as basically saying that there's lung injury, right? Like chest injury, chest wall, but it's talking about lung injury. So I would just think about it like if your lung is gonna pop. So it's like the balloon is gonna pop. And the reason why is because I think it just makes it a little bit simpler to understand. Like, okay, you don't want an injury to your lungs. So your pressure is limited. You do not have to um, worry about your lung popping, right? And that is a injury. Absolutely. If you're putting too much volume, which we'll get to in a second, you're putting too much volume. Eventually, it's going to pop, right? So with pressure, we're limiting it, and we're going to make sure that it's not going to pop that balloon. But for the tidal volume, hypoventilation, respiratory acidosis, those are the disadvantages because again, we're talking about pressure, how much we're pushing. We don't have a set tidal volume. And really, she won't really be asking that, but just keep in mind, like with the uses, usually you should use it for ARDS and you'll learn about that. And you'll learn about kind of why we don't want a lot of pressure. And then same thing with the neonates. And it makes sense because in both of these cases, your lungs are super fragile. And if you were to put more pressure, if you were to focus on the volume instead of the pressure, you're again with the volume, if you're blowing into a balloon, you're gonna pop it. You're gonna hurt it. You're gonna hurt the balloon, it's gonna pop. And then obviously if it's your lungs, ooh, that's really but that's as Mandela says, that's really, 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 really bad. Um, so with ARDS and neonates, right, they're super fragile. So you want to focus more on a pressure setting rather than a volume setting. So that's basically what we're differentiating. So pressure, how much force does it take to get air into the lungs? But at least I get to regulate that. And even though I'm not regulating the volume as much, the good thing is I'm focusing more on that because I don't want more volume. I want more pressure. Because again, those are very fragile cases of having your lungs being very fragile. For volume, this refers to the amount of air that enters the lungs with each breath. So how much actually air is giving. So again, in that balloon, I'm blowing it up. That's what it's saying. How much air I'm blowing up. Whereas with the pressure, how much force am I forcing to push air into the lungs? So either way, they're both getting air, but it's two different types of styles of how we're doing it. So the advantage with this one, it's like it's basically having natural respirations, it's more comfortable, and you're actually guaranteed a tidal volume. So with the other one, the thing is though is we're talking about force, so I'm not gonna be able to know 100% how much tidal volume in terms of how much air the person's actually getting. I'm just pushing more air into them. Um, but again, pushing as in the force. I'm changing the force. We don't know how much air they're actually getting, but I know that they're getting some because I'm forcing it in. But we want to regulate how much they're getting, so that's why we focus on the pressure. Whereas with volume, oh, we can give them however many volume. But again, the disadvantage to that is the barotrauma. Again, thinking about like, okay, barotrauma, like the balloon's gonna pop, the lung's gonna pop. If you give more volume and volume and volume, eventually, yeah, it's done. So again, the uses are in most patients or in aura settings because we can handle that. Our lungs are strong. They can handle to be expanded. They can handle that volume. But for people with really fragile things, we're gonna more try to force air into it and not focusing on the volume, but rather just being like, okay, we're gonna push the air. Whereas the volume is like, no, it's not talking about necessarily about pushing, it's literally how much air. So literally volume versus pressure. Exactly what the names are. Take it literally in a sense. Um, so now I'm gonna talk about the settings. So I don't think you guys went over the modes, so I don't think I will, but I think next week, if you guys do go over it, and if you did end up going over it, let me know because the modes can be very difficult to understand. And I feel like you need somebody to kind of break it down. And I feel like I kind of did, and it does make sense, but even I still am like, okay, But let's get into it. So respiratory rate. So respiratory rate um basically how many set of breaths, we already know what this is, right? How many breaths, and you can set this on the ventilator, so how many breaths the patient is actually getting. And so this is based off of how hard they're working, their comfort level, things like that, right? So tidal volume, the amount of air delivered with each preset breath. So how much air, the amount of air am I giving with each breath? So you have the respiratory rate. So if I'm saying 12, and then I say respiratory rate 12, tidal volume 500, I'm giving 500 mLs um, per each breath. And you think that's a lot, but it's just the amount of air with each set breath. The difference between that and FiO2, FiO2 is the concentration of how much air you're giving. So remember when it's like you're giving like a nasal cannula at like 2 liters, um, that's what we're talking about. Kind of more of the tidal volume. Whereas with the FiO2, we're talking about the percentage of oxygen that we're giving within those 2 liters. So if I say in that question, right, I'm giving 12, I'm giving this patient he has a respiratory rate, or the vent setting is set to 12 for the respiratory rate, and the tidal volume set to like 400 mLs. FiO2 is 30%. That means for every single breath, I'm giving 500 mLs, and the concentration of that will be 30%. Um, so percentage of oxygen a ventilator delivers to a patient to increase oxygen levels in the blood, right? So that's just the concentration. It tells us what we need to know. And so obviously that differs. Remember with the nasal cannula versus the non-rebreather. Remember those percentages? You don't have to know those percentages, by the way. But it's just understanding the concept of like why that's there, right? And that's adjusted based off of their ABG or pulse ox values. So PEEP and CPAP are the exact same thing as how I would think about it because it's continuous airway pressure. So it's literally just keeping your alveoli open. And that's exactly what PEEP is too. Positive and expiratory pressure into the airways during expiration. So it's during um, both really, but really what it does, it prevents the alveoli from breaking down. So that's literally it. It just keeps the alveoli open the entire time. And that's actually not a bad thing because sometimes for these patients, it's like you want to keep it open because sometimes you want to keep that gas exchange um, in a cycle. And the problem with it's if you don't have PEEP, sometimes I guess the problem would be the alveoli would collapse at a certain point, right? So basically, the normal range is from 5 to 20. 20 being like, yikes, they really need a lot of help. But 5 normal. Like for obviously it's not normal. You shouldn't really need PEEP. But the thing is though 5 being like the best option that we can get. So not bad at all. I don't even think I've seen a 20. Usually in the hospital I saw like 5s. But adverse effects, barotrauma, right? Because you're keeping the alveoli open the entire time. And it's the same exact thing as how we talked about with like the volume. It's like you're just keeping it open and it's like, okay, you can definitely create some lung injuries with that, if that makes sense. IE ratio. So this is basically like inspiration in comparison to expiration. And you can change this, right? So usually it's set at 1 to 2. And that basically um, mimics this pattern of spontaneous ventilation. With ventilation, we can change it so there are longer expiratory times to promote more complete exhalation and reduced air trapping. So it's set usually 1 to 2, and then with the inverse IE ratio, basically you're reversing that, right? So you're going to make um, that inspiration sometimes a little bit longer than the expiration. So really it's just based off of what the patient has in their diagnosis. So if they need improved oxygenation with non-compliant lungs, they can use that. So this is basically giving the alveoli more time to reopen during the inspiratory phase and stay open longer during the expiratory phase. So that's basically, you can mimic that. So basically it's not really We don't really talk about it that much, I'm gonna be honest, but I feel like it's important to know when you talk about certain modes because they have IE ratio, and one of them specifically does. So basically just know that normally inspiration is shorter than expiration. So really what we're doing is we're inversing that because we want them to have more air. So it's like we're inhaling, we're picking up more of that O2, and then we have more of that available for the gas exchange part. Does that make sense? I feel like when I was explaining it and just reading it, I was like, it's still a little bit complicated. But really, inspiration normally shorter. We're making it longer because we want more gas exchange. We want more O2 available. And then in terms of alarms, sorry, I had to drink really quickly. My throat is hurting. But so in terms of alarms, we have high peak pressure, low pressure, and then apnea, low exhaled volume, all of those things, right? So for those things, high peak pressure, I want you to think about it like an obstruction. That's literally it. And I'm getting this straight off of Mark K because he actually explains this pretty cool. So he just says high peak pressures. So high, if you hear the high pressure alarm, that means there's an obstruction. So okay, some of the things like secretion in the tubing. So what are you gonna do? You can suction them, right? Um, there's other stuff in the um, ventilator. Okay, take it out. Like, so it's pretty simple actually, but just think about it like there's literally an obstruction. So if there's water, if there's secretion, there's kinks, unkink it, right? If they're caulking, talking, and gagging, well, you're having resistance, right? You're having resistance to that because if you're talking against your vent, um, you're not letting that air come in. So you're going against it. Coughing, gagging, all makes sense, right? And that's when you kind of call RT and you're like, hey, I think the patient keep talking and um, everything, so they might need to be weaned off a little bit because it seems like they're able to do stuff on their own a little bit. So low pressure, basically what that means is I would think about it as disconnection. So something's disconnected. So there's leaks or it's disconnected. Okay, so what if it gets disconnected? Connect it back. That's not like a chest tube. Do not get that confused. Because again, when you're in, I think it makes sense for people who are in the ICU setting, right? When you see the actual vent, there is times where it will unplug itself, or even a patient will take it off. You have to put that patient's hand down and put that ventilator back on. That's all you have to do. Don't freak out about that. If there's leaks, you check the tubing, right? If there are leaks, is there something that I don't see? Um, and then you check that out. And then low exhaled volume, it's the same exact thing, but the other portion that you have that you can add to it is that what if the patient just has fatigue or no, their lung compliance is just not there. And then apnea, they're no longer breathing. And for that one, makes exact sense because that's what apnea is. Um, so we won't go over the modes. There's a lot. So I don't know if you guys had to know the wean screen. We got told that we had to, memorized it, didn't need it. So I would maybe, if you need to, just write it down a bunch of times. That's what I did, and just straight up memorized it. Um, it was like some math down here, but anyway. So with the things to the right that you have to know for the vent stuff. So I will explain that because it is a little bit confusing, but I will explain that in the exam questions. So I would just say to kind of understand that. So if my PaO2, and then she'll give it to you like this in a question. Okay, the patient is on ACVC, which means they're on assist control. That means like they're getting ventilated. They're getting ventilated good because they cannot probably breathe. So because of that, the PaO2 is, and she'll give you values like tidal volume, 400, respiratory rate 12, PEEP plus 5, um, FiO2, whatever percent. And then she'll give you the values like PaO2, PaCO2, and it'll be like, if it's above the 80, you know that it's going to be the increase. If it's below the 80, you know it's below the decreased, right? So the desired outcome, it's below 80, you want to increase the oxygen. If it's obviously too high oxygen, you want to decrease oxygen. And I guess the question is why would we want to decrease oxygen? Well, you can have too much oxygen. There is such thing as oxygen toxicity, right? For the PaCO2, okay, 35 to 45, same exact thing, right? So if it's too low, then what do we want to do? Well, we want to basically retain CO2, right? If PaCO2 is increased, so it's above the 45, what do we want to do? We want to blow up CO2, right? So I would just think about it again. remember I said earlier with like respiratory alkalosis and acidosis, this is basically kind of what we're talking about, but for the PaCO2 at least. Like the hyperventilation versus hypo. So if PaCO2 is decreased, that means currently my patient is hyperventilating because they're getting rid of all of that CO2, right? So I want to retain that. So how can I retain that CO2? Well, we talked about those settings, right? So you want to decrease the respiratory rate. And then also you want to decrease the tidal volume because remember with the tidal volume, how much air am I getting within a specific amount? So if we give them more air, the ratio between CO2 and O2 is a little bit changed, right? And then with PaCO2, it's increased. So that basically means that I'm hypoventilating because a CO2 is an acid. That means I'm retaining it. So if I'm retaining it, I'm not breathing. We're not breathing, it's staying in there. So I want to be able to get rid of that CO2. How can I get rid of that CO2? Okay, you increase the respiratory rate and then you increase the tidal volume with that because then you're going to be able to blow all of that out. The other factor to that, PaO2, if it's decreased. So if it's below, so the normal range 80 to 100, right? Below the 80, we want to increase it. So FiO2, that, remember that's the concentration of oxygen of what we're getting. That's actually a really good thing. And then with PEEP, that's what keeps your alveoli open for the entire time, just like CPAP. But why would I want higher PEEP, like for PaO2? Well, remember the whole entire thing with PEEP, keeps it open the whole time. Why do we want to keep it open the whole time? Well, we want more gas exchange to happen if we keep that alveoli open the entire time, right? So more gas exchange, more O2, and more O2 is able to go to our capillaries, our alveoli that we talked about, and go to the rest of the body. Higher PaO2, congrats. So I would think about it like that, and then obviously if the PaO2 is too high, so above that 100, you're going to decrease the FiO2, decrease the oxygen um, uh, concentration, and then you're going to decrease the PEEP because you don't want to keep it open the whole time because they don't need it. So that's basically how it works, and we'll get into that with the questions. And then last but not least, in terms of the mechanical ventilation, those things that you have to know, I would just straight up memorize them. But if you think about it, it makes sense. At a certain point, we have 7.35 to 7.45, but at a certain point, 7.25 or below, that's pretty bad. And that's not pretty bad, that's bad. But that's definitely not something where remember when we are talking about the oxyhemoglobin curve, right? When we're talking about it being acidotic, we're more sitting on that right-hand side, so we need more oxygen. So if we need more oxygen, because remember we need less attraction to the hemoglobin and the O2, so then if they're having less attraction, the oxygen can run freely around, go crazy, and then it can go to me what I need. So it's less than 7.25, it's acidotic, it's on sitting on that right-hand side, so that's why it's like, okay, we need more oxygen as a whole. Because we need more oxygen because of the metabolic needs, that means you need to be ventilated. The next thing, CO2, 35 to 45. Now it's above 50, so that's even higher. So good indication to ventilate. PaO2 below 60. Definitely not good. It's supposed to be like 80. So, yep. And then respiratory rate. Yep, definitely high. Usually, I think in school we learn like 12 to 24 ish. It kind of depends though. Sometimes it's like 12 to 20, but usually I would say like 12 to 24 is the normal range. And either way, she won't give you something like that. She'll say like respiratory rate like 35, 40. It's pretty high. So, again, and you're seeing too their symptoms, dyspnea, worker breathing, all of those things, right? So that's basically how it is. And then I put if intubated, bilateral lung sounds assessed first, and then you look at the CO2, the end tidal CO2 next, and then you do a chest X-ray and all that stuff. But she didn't even ask that. It was straight up just these indicators and what you have to know. In terms of the rest of the stuff, just read it if you guys went over it. She just told us to know 7.5 to 8.5 for the adult sizes. She didn't test us over this. I think it was just to know for ICU people, and then just go over the pneumonia. But I don't even think you need to know that either. It makes sense, right? Secretions, elevate head of bed, hand washing, prevent those things from happening when they're on a ventilator. But other than that, let's go to the questions. Okay, so let me see where I'm at in terms of